Welcome back to today's CME, in which we are going to learn about electrolyte disorders management, which is actually one of the most common disorders that you will observe amongst our hospitalized patients. Electrolyte imbalance is actually a very broad topic. In these presentations, I will be focusing more on the clinical treatment aspect. I will begin the lecture by giving you some general principles in how to manage patients with electrolyte imbalance. After that, we will discuss in depth about the clinical treatments of each of the specific electrolyte imbalance as illustrated in this slide. And lastly, we will quickly sum it up by giving you the potential clinical pitfalls that might happen if you do not take the necessary precautions. The first and also the most important principle is that when you encounter a result that's too high or too low to be true, please always be skeptical about it, especially when it doesn't fit into the patient clinical status or it was an isolated result derangement that doesn't follow the trend. This is important because sometimes it could be the artifactual errors, or worse, it could be a wrongly labeled samples. Next, you should be able to correlate certain clinical conditions that will give rise to pseudo-electrolyte imbalances. As the name suggests, it's not a true electrolyte imbalance, hence it doesn't require corrections. Also, you should be able to determine the rate of electrolyte corrections, which largely depends on the patient's symptoms as well as the level of the electrolyte. And the final principle is that to always identify the root cause and to treat it accordingly. First, let's take a look at hyperkalemia, which is a potentially life-threatening condition. The reason being is that a critically raised potassium level would actually predispose the subject in developing life-threatening cardiac arrhythmias, and sometimes the patient may develop cardiac arrest as a result. So for HTAR, we actually use this indirect ISC test method in measuring our patients' electrolyte levels. And for serum potassium, the normal range would be 3.5 to 5.5 millimole per liter. But in practice, generally, if the patient's potassium level is above 5, it should actually trigger your attention because by and large, most of the patient potassium level would be less than 5. Hyperkalemia subjects normally have a very non-specific presentations, but overall, most of them would actually have some form of renal insufficiencies. Hence, you should always look for other supportive evidence like whether the patient have CKD, or is the patient suffering from acute kidney injuries, Addison disease, or you have the patient recently been given massive blood transfusions. In order to ensure that the hyperkalemia you observe is actually a true occurrence. Also, more objectively, you should order an ECG to look for hyperkalemic changes, which are actually represented by tall tented T wave, small P waves, or YQS complex, or sometimes in the very critical hyperkalemia state, the patient may actually manifest with ventricular cardiac arrhythmias. Another important fact to highlight is that potassium imbalance would have a direct effect in the patient's acid-base homeostasis. Hence, in the subject of hyperkalemia, we should always measure the venous blood gas to look for concomitant metabolic acidosis. Let's learn about pseudo-hyperkalemia first before we talk about the treatment strategies. This is important because pseudo-hyperkalemia is actually not a true state of hyperkalemia, hence it doesn't require corrections. So this can happen in a few situations, but ultimately the underlying cause for this happen because there is a potassium leakage from the intracellular space. That can happen because of hemolysis due to difficult blood taking, or patient clench his fist too hard when you are performing your unit punctures. Not uncommon, it happens because of a delayed analysis. It's also important for you to be aware that patients with hematological disorders, not uncommonly, they would also have pseudo-hyperkalemia. So this is especially more prevalent in subjects with raised cell counts, like for example polycythemia or leukocytosis. This happened because of the blood samples that were kept in the tube easily would have leakage of potassium from these elevated cell counts. Therapeutic strategies for patients with electrolyte disorders would largely depend on the patient's symptoms as well as the degree of electrolyte disorders. So in the case of chronic or stable hyperkalemia, which are very commonly observed in our patients with chronic kidney disease, they will be managed with this oral kalimate, which is actually a form of calcium polystyrene sulfonate powder. The mechanism of action of oral kalimate is actually by reducing the gut absorption of potassium, and it will help bring down the potassium over a few days, Because of these delay effects, hence it's not a drug of choice for patients with severe or critical hyperkalemia. So another point I think all the healthcare workers should be aware of is that usage of oral calamate has been rarely associated with a colonic necrosis of perforations. Hence, in any patients who actually have concomitant GI symptoms, oral calamate shouldn't be prescribed. Moving on, we are going to discuss about critical hypokalemia. By definitions, a plasma potassium level that is more than 6.5 millimole per liter will be considered as critical and require urgent interventions. In practice, generally, any potassium level that's more than 5.5 should trigger an action that includes giving a Lytic cocktail or triple regime. Lytic cocktail or triple regime actually have three components. So let's look at it one by one. So the first component that we would serve would be this 10 ml of calcium gluconate 10% over 5 or 10 minutes. So the mechanism of action of these drugs is actually to reduce the cardiotoxicity effects of hyperkalemia by stabilizing the cardiac membranes, because as you know, critical hyperkalemia does increase the risk of life-threatening or even sometimes fatal cardiac arrhythmias. So after stabilizing the cardiac membranes, you should serve D50%, which actually act to prevent the development of insulin-induced hypoglycemia later. So in other words, it doesn't have a direct effect in lowering the potassium levels in the subjects. So another point to highlight is that by and large, the nurses, the doctors, they tend to give 50 ml for every subject. But keep in mind that this the amount of dextrose to be given to the patients receiving Lytic cocktails are actually subject to changes depending on the patient's sugar trend beforehand. So lastly, we will serve 10 units of IV insulin in a bolus, which will act by driving the potassium into the intracellular space. As you can see here, Lytic cocktail doesn't actually eliminate the potassium from the patient's body. What it does is just to provide a subject more time before a more definite treatment could be instituted, like hemodialysis, or maybe it will work if the patients have only very mild or little renal impairments. Hence, most of the time in patients with very advanced renal disease, they will require more than one times of this Lytic cocktail, because the Lytic cocktail effects sometimes can be quite unpredictable. So lastly, we will serve 10 units of IV insulin in a bolus, which will act by driving the potassium into the intracellular space. As you can see here, Lytic cocktail doesn't actually eliminate the potassium from the patient's body. What it does is just to provide a subject more time before a more definite treatment could be instituted, like hemodialysis, or maybe it will work if the patients have only very mild or little renal impairments. Hence, most of the time in patients with very advanced renal disease, they will require more than one times of this Lytic cocktail, because the Lytic cocktail effects sometimes can be quite unpredictable. These are the components of a Lytic cocktail, which include calcium gluconate, your Actrapid, as well as your D50. So the reason why I want to put up this in a single slide, because I think mistakes happen before. I have mentioned earlier to you, during these Lytic cocktails, you only need 10 units of Actrapid, and the way to administer this 10 units of Actrapid is via this insulin syringe. So which is actually distinctly different from the normal syringes that you are using. So as you can see here from the label here, 1 ml of Actrapid from these insulin vials, right, actually contains of 100 units of Actrapid. So 10 units of Actrapid is actually very minute. Hence you need a specialized needle, which is the insulin needle, to aspirate these amounts of insulin. Hence, normally for me, after serving these IV insulins, I tend to flush it because the amount is just too little. So I will make sure that the 10 units of insulin truly enter the patient's body system. As I have alluded earlier, please be very careful when you are serving this IV insulin bolus. Make sure that you only give the right amount, which is 10 units of IV Actrapid. So any mistake in giving wrongly, like for example 1 ml of IV Actrapid, it can cause refractory or sometimes fatal hypoglycemia. So another point to drive home is that please be careful with the IV D50 that you are giving. Always review the patient's sugar or dextrose trend before deciding the amount of dextrose to be given. Not uncommonly, we have seen patients suffering from iatrogenic diabetic crisis like HSS or DKA because the doctors didn't review the sugar chart beforehand. So what I suggest is that if the patient's sugar is persistently more than 15, please consider reducing the amount of dextrose bolus required. And sometimes you may even consider omitting it, say the sugar was already at a very high level. Also, always repeat the BIOS level 1 hour after Lytic Cocktail. Like what I say, for patients with severe renal insufficiency, they most of the time will require more than 1 times of insulin chase. So these are the other measures that you can take in a subject with hyperkalemia. But by and large, this group of treatment will only work if the patient is actually a non-oliguric subject. For example, like by giving these loop diuretics like furosemide or by giving sodium bicarbonate. So to highlight, beta agonist nebulizer treatment you may come across in a medical textbook, but in practice we don't really give nebulizer treatment for a few concerns. First, it will cause tachycardia, which is actually uncomfortable for the patients. And second of all, in nowadays this COVID pandemic, nebulizer treatments will be discouraged. So lastly, just to emphasize again, patients with any rate oliguric subjects, the definite treatment would be dialysis depending on the potassium level as well as the patient's renal functions as well as any other indications for dialysis. So moving on, we'll talk about hypokalemia. So by definition, hypokalemia is defined as a serum potassium level that's below 3.5. So the clinical symptoms normally would include muscle weakness, hyporeflexia, muscle cramps. Sometimes it may cause lightheadedness. Rarely it may cause constipations as well in certain subjects. So the supportive evidence for patient hypokalemia would be ECG changes. So you should look for small or inverted T waves. Sometimes the patient may develop prominent U waves or long PR interval as well. So we should always review the patient medications. So very common culprit drugs to cause hypokalemia in the subject would be use of diuretics, for example, like these hydrochlorothiazides or furosemides. So one important fact to highlight in this slide is that potassium imbalance actually have a direct effect in acid-base homeostasis. Just as in the case of hyperkalemia, like I mentioned, they will normally be associated with metabolic acidosis. For hypokalemia, commonly it will be associated with metabolic alkalosis as well. But however, if you see a subject with hypokalemia that has a concomitant metabolic acidosis, please consider the fact that the patient might possibly have a renal tubular failure, which requires specific treatments. So these are the treatment for patients who have a very mild or asymptomatic hypokalemia. So you may consider giving slow K as a maintenance drug for this group of patients, or you may consider giving mixed KCl for short days, for example 3 days. Just to highlight to you that most patients find that mixed KCl is actually very unpalatable because it has quite a bad taste. Hence, please do not prescribe this mixed KCl for prolonged durations. If patient require long-term potassium maintenance, please consider the other options like slow K. If your subjects require IV drip during admissions, you can always supplement the potassium into the IV drip that the patient is receiving. So let's talk about severe hypokalemia that require fast corrections. So the way we prescribe will be normally we'll give 1 gram of KCl diluted in 100 cc of normal saline to run over 1 hour. If the level of potassium to be like, for example, very critically low, say potassium level of 2 or 2.5, then you may consider giving a higher volume of mixed KCl. But please remember that it should be diluted in larger amounts of normal saline over extended hours. For example, it can be up to like 2 hours. And always repeat the potassium level 1 hour after the corrections. Please remember that KCl corrections must always be given as forms of infusions. For example, like 1 gram over 1 hour or 2 gram over 2 hours diluted in this normal saline. So generally, the guideline will recommend that the maximum potassium replacement per hour is 40 millimole per hour, which is equivalent to 2 grams per hour. But in practice, this is rarely happening because we are actually taking a much safer approach. We will tend to give, if really critical hypokalemia, we will give around 2 grams in 200 cc over 2 hours, which is only 26.8 millimole over 2 hours. So this is just to be safe, to ensure that we did not inadvertently serve the KCl as a bolus, and also more importantly, It will reduce the chance of developing phlebitis or pains during these KCl infusions. So it's also important for you to measure the patient's plasma magnesium level in the patients that came with hypokalemia, because quite commonly hypokalemia happens in association with hypomagnesemia as well. In fact, an uncorrected hypomagnesemia will cause retardations in the patient's potassium normalizations, mainly because hypomagnesemia itself is actually associated with urinary potassium wasting. Hence, please always correct any concomitant hypomagnesemia in the subjects with hypokalemia. So another point to highlight is that please always keep in mind that pseudo-hypokalemia would happen, say if the blood is taken from an arm that has IV fluid infusions. But generally, this will be obvious to you, because I'm sure that potassium will not be the only electrolyte that appear erroneously low. So next we'll talk about hypernatremia. So by definition, the patient is deemed to have hypernatremia if the measured plasma sodium is above 145. So the basic mechanism for hypernatremia are normally due to water deficit or an excess of solute, which is sodium. But in most of the case, this happens because of excessive water loss. Hence, the clinical manifestation normally will indicate that this patient has some, forms of dehydrations, such as like thirst, weakness, lethargy. In the very extreme forms, the patient may have altered sensorium, for example, reduced consciousness. At times, they may actually present with seizures activity. Similar to the previous electrolyte disorders, it's mandatory that you must review the medications in any subject with electrolyte disorders. In the case of hypernatremia, you always will review the meds to look for whether are they on any forms of diuretics that's causing excessive diuresis, and also to ask whether did the patient have any GI losses recently, and also examine for signs of dehydrations. And lastly, always determine whether this is an acute hypernatremia or is it a chronic hypernatremia. Management strategies for acute or symptomatic hypernatremia lies in identifying the cause and correcting the hypertonicity state. In the subjects who were hypervolemic at presentations, the first goal of treatment lies in restoring the intravascular volume by using the isotonic solutions, for example like normal saline. On the other hand, if the cause of hypernatremia is not due to severe dehydration, then we should administer less tonic or hypotonic solutions for these subjects. A common example would be your QSD1 or your pure dextrose solutions, like your T5 solutions, in order to reduce the plasma tonicity, which will actually bring down your plasma sodium level as well. So how fast or how aggressive of this correction would largely depend on the patient's symptoms as well as the degree of hypernatremia. Keep in mind that in the subjects that's on rice-fuel feedings, we can always have the options of adding extra water into the feedings, and you can always collaborate with the dietitians with regard to this. A common example would be we'll add 100 cc of water during each feed. That would also help in terms of like bringing down the serum sodium level. A note of caution when correcting sodium level in both hypernatremic and hyponatremic subject is that the sodium collection rate shouldn't be more than 10 millimole per liter over 24 hours. This is important because a sudden or a rapid drop in the plasma tonicity, especially when there is a large fluctuation in the sodium level that's more than 10 millimole in 24 hours, it will predispose the patients to developing a condition known as osmotic demyelination syndrome. The only way to prevent this occurrence is by monitoring the patient very closely, for example, by repeating the bills either 8 hourly, 6 hourly, or even more frequently. Ultimately, it depends on how fast is your corrections. So next, we will be looking at hyponatremia, which is another common electrolyte disorders that you will observe in our hospitalized patients. So again, the clinical manifestations are rather non-specific, but in the extreme stage, the patient would actually have an altered mental state and sometimes may actually present with fitting. So again, in order to ensure that this is a true hyponatremia, we will always review the patient medications, assess the patient fluid status, whether the patients have a cardiac failure or liver failure. But keep in mind that patients with CCF or liver failure, they would have chronic hyponatremia as long as they are asymptomatic. Most of them doesn't require any corrections. And also most importantly, you try to determine whether this is an acute or chronic hypernatremia. So by definitions, acute hyponatremia is defined as the occurrence of this low sodium state that happens within 48 hours. So if any hyponatremia that lasts more than 48 hours, then it will be considered as a chronic hyponatremia. Just to highlight that in certain populations, because of the underlying comorbidities, for example, like chronic liver failure or chronic heart failure, most of them would generally have a lower plasma sodium compared to the general populations. And most of the time, we will not initiate treatment unless the patient is symptomatic. And generally recommended, the threshold for actions will be when the plasma sodium falls below 130 millimole per liters. But my advice to you is that don't treat the number, treat the patient instead, because sometimes as long as they are doing well without any symptoms, sometimes we may not actually attend to the low sodium that is actually a silent bystander. In patients with critical hyponatremia presenting with seizures or coma, we will provide rapid corrections of the plasma sodium. So the treatments will be administering 3% hypertonic saline, 100 cc over 30 minutes, and to repeat the plasma sodium within 1 or 2 hours, and KIV further bolus corrections if the goal of sodium hasn't been achieved yet or the patient is not improving. In practice, generally the hypertonic saline to be given a subject in such condition will not be more than 3 boluses. So this slide is just to reiterate to you that the sodium correction rate has to be monitored very closely in the process in order to not subject the patient to develop osmotic demyelination syndrome. Just to emphasize, patients with pseudo-hyponatremia doesn't require any actions. So the common cause of pseudo-hyponatremia would be if the blood was taken from an arm with an ongoing infusion, therefore you have a diluted samples, or high serum lipid or protein content will also cause a hyponatremia. And also lastly, patients with hyperglycemic crisis or DKHSS, they may have hyponatremia presentations, and the goal of treatment is actually to correct the sugar, and automatically the sodium will pick up. Another medical disorders that's worth mentioning is this SIADH. So it's actually a syndrome that will give rise to hypoosmolar hyponatremias, which means that the patient will have a reduced plasma osmolarity. At the same time, the urinary osmolarity will be raised with a raised urinary sodium. So the treatment options for these disorders is actually fluid restrictions, and sometimes you may consider tolvaptans. But in practice, let's say you have a clinical conundrum, not knowing whether it was truly a hyponatremia due to SIADH, which need fluid restrictions, or was it a hyponatremia due to a fluid loss or dehydrations. You can always give them a trial of fluid hydrations. Most of the time, with fluid hydrations, the sodium level in SIADH would actually drop further. On the other hand, if it was a hyponatremia due to dehydrations, you'll be expected to see the sodium level to normalize as you hydrate. Next, we'll be looking into hypomagnesemia. Hypomagnesemia generally would not have an important clinical implication, and hence most of the time to well subjects, even though they're hospitalized, generally we do not measure their microelectrolytes unless there is a clinical need. So overall, the clinical manifestations for hypomagnesemia are rather non-specific, and at times it can also mimic the other electrolyte disorders or manifestations. For example, they may cause paresthesia, ataxia. In the most severe form, it will cause seizures, or sometimes it will cause cardiac arrhythmias. Just to highlight to you 2 clinical scenarios that you must always look into their serum magnesium level. I think the first will be those subject to hypokalemia that I have already explained to you earlier on. So now I just want you to get to know that patients with acute STEMI should always have their serum magnesium level monitored, because hypomagnesemia is actually pro-arrhythmia. So generally in practice, if a patient came with STEMI, if the serum magnesium level is below 1, we will tend to replace it, because we know that hypomagnesemia is actually pro-arrhythmic conditions, especially during the acute phase. So just to illustrate to you, this is our magnesium sulfate ampule, and 1 ampule actually contains 2.47 gram of magnesium sulfate. So in practice, normally you'll cover this MAXA. So for information, magnesium sulfate actually have a diverse usages. So it can be used to treat acute hypomagnesemia, like what I mentioned in this lecture. It can be used for, as a treatment for patients with eclampsia in our pregnant mothers. It also can be used as bronchodilators for patients with acute exacerbations of bronchial asthma or COPD. So in practice, normally we'll dilute this 1 ampule of MAXA in 100 cc normal saline and to run it over 30 minutes to 1 hour. So next, we are going to look at hypophosphatemia. In general, we do not routinely measure someone's phosphate level unless they are critically ill. Like example, for those patients who are from ICU, and if there's a need to correct the hypophosphatemia, we will give these medications, which is known as glycophos. We will dilute it in 100 cc of normal saline and infuse this over 6 hours. So we'll be looking at hypocalcemia in this slide. So the clinical manifestation for hypocalcemia will be like muscle cramps, perioral numbness, paralysis, and seizures. And I think the classical signs that I think all the textbooks mentioned will be these social signs, and also the Chostak sign. Basically, Chostak sign is a sign that there is neuromuscular hyperexcitability, especially over the facial nerve. In a patient with acute symptomatic hypocalcemia, we'll administer calcium gluconate 10%, 1 ampule over 10 minutes. I think it's important for everyone to know that hypoalbuminemia will cause artifactious hypocalcemia. Hence, in clinical practice, we will only use the corrected serum calcium level in deciding our clinical managements. So this is a formula for you to calculate the corrected serum calcium. Basically, it's 40 minus the measured plasma albumin times 0.02 plus the measured plasma calcium levels. So this will be an example to guide you on how to use this formula. I would like to end my presentation with 3 notes, which always treat the patient and not the numbers, and always repeat the test if you are skeptical about the results. And you need to have a sound knowledge about the pros and cons of fast corrections for each of electrolytes. So thank you for watching until the end. I hope you have gained some new perspectives in how to manage patients with electrolyte disorders. And please subscribe to the channels and share the videos with your friends who might benefit from this as well. Thank you.